Longevity Junky is presented to you by our friends at 8cast. Hello, Longevity Junky. It's time to get your fix. I'm Nikki Leigh.
I'm Buck Joffrey.
And this is a two-part episode all about how we're using tech for longevity. We're going to look at one great way to use Medicine 3.0 to take control of your health by talking about full-body MRIs with Dr. Sefi, who is a radiologist. Also, we're covering a need-to-know section about Robert F. Kennedy's brainworm. All right, so first let's catch up. Buck, how have you been?
Well, the usual. Waiting for, my eye bubble. We talked about my eye bubble in the past. Waiting for my eye bubble to get smaller. So that's exciting. Yeah, that's what I have to report. Now, I heard you went to Africa.
I did, yes. I went to Kenya, Africa. I went on a keynote speaking tour, and I went to oh my gosh, I went to so many schools for youth, going from, grade 1 all the way to university. And so I would go and make these speeches. And this is the first time I've done these like motivational speeches and, up with a microphone. I planned it all out. I have a point to drive home. And it was all about positivity and the power of mindset and, really instilling in the youth out there that they have all the power within them. They just have to believe in themselves and to let them know that I believe in them. And there's someone out there that does.
They seem pretty excited to see you. You were like a movie star and stuff, and you were coming out of there. It was kind of cool.
It was really cool. Honestly, I have to say, I had the warmest welcomes I've ever had in my life. And I was just like, am I here for me right now, or am I here for you? Because this is just feeling really good.
Don't you get tired? I get tired.
Yes. I think it catches up at me sometimes because I am a creature of routine. Like I'm sure we all kind of are. When I get into a good flow of routine, I feel at optimal level, and I haven't really been able to be in one this year. And so, yeah, I feel like I get these like moments of exhaustion.
Honestly, I was thinking the same thing because I'm kind of fatigued today too. And
so you're checking your sleep score. I mean, that's kind of our Medicine 3.0 that we keep talking about, gamifying our, our health.
Well, that's certainly part of it. And by the way, we probably should give credit. I mean, the whole idea, this concept, calling it 3.0, Medicine 3.0 is from Peter Attia, and it's a great way to describe it. But, the idea being that it's like, you're going to be able to take medicine into your own hands and use technology like the Oura Ring. And you're absolutely right. One of the great benefits of tracking your data is that we're all sort of naturally inclined to, to compete, right? And when we see numbers, we want to do better. And a lot of the time, it's like things that aren't necessarily good for you. But this is a situation in which it's not just about playing a video game or something like that and getting the high score, but it's like, okay, well, if I go to bed earlier, I'm going to get like a better score sleeping. So I don't know. It's kind of a strange thing, but it works. It really does work because I've changed a lot of my behavior based on trying to get better numbers.
Well, yeah, but it brings about awareness. And I really feel like in life in general, whether it's, gamifying our health or anything like that, awareness allows us to change our behavior. So it really is a benefit. Okay, how about we go into our segment of Need to Know?
I thought it would be interesting to talk about this thing that happened with Robert F. Kennedy Jr. So a lot of people know Robert F. Kennedy Jr., let's just call him RFK. He had this brain worm, right? And so back in 2010, he started experiencing some symptoms. He was having brain fog, memory loss, some headaches, and general cognitive stuff. And like he should, he went, to get some medical evaluations, including an MRI of the brain. And this was at around the same time that Teddy Kennedy, his uncle, died of his brain cancer of glioblastoma multiforme, which is a very aggressive type of brain tumor. So he was initially kind of scared that he had the same thing. And so he got the MRI, and that was the initial diagnosis that he was given, that he had a brain tumor. But as it turns out, it wasn't a tumor at all. He actually was dealing with a parasitic infection called neurocysticercosis. Now, that's a mouthful, right?
Yeah. Wow.
Yes.
Does this have anything to do with like his, I don't know, that tremor or whatever, that his speech that people really focus on?
Yeah, that's a good question, actually. As it turns out, that actually is completely something very different. It's a relatively rare disorder of the vocal cords called spasmodic dysphonia, and that's a separate thing. It's not really health. It's nothing that's like life threatening or anything, but a big inconvenience. Right. And people can actually benefit with a little bit of Botox to the vocal cords, believe it or not. That's one of the ways that he's actually able to improve his speech enough to actually talk. Because usually when you have spasmodic dysphonia, it's pretty bad. And, he's doing speeches and stuff like that. There's no way he could do that.
I know.
But in terms of this, the neurocysticercosis, it's actually a parasitic infection of the central nervous system. When we say the central nervous system, we're talking about the brain and spinal cord, right? And it's usually caused by eating the larva of a pork tapeworm. So, he's talked a lot about how he's traveled a great deal in Africa and South America and Asia because he was an environmental advocate. So he did a lot of traveling, and he's also made he's also talked about how he'd go in and he'd just eat everything and do whatever the people in the space were doing. Yeah. When in Rome, right?
Yeah.
But from a medical perspective, let's talk a little bit about what happens. So parasites like this one, they don't actually eat your brain tissue. What they do instead is they form these little cysts, and they can actually kind of displace portions of the brain. And in that regard, kind of like a tumor would, right? And like real estate, it's all about location. And so that's really how, the different symptoms come up. Just like with brain tumors, somebody might have a visual disturbance because the tumor is sitting in a visual center or something like that. Same thing goes for this. He got diagnosed with this, and it hasn't changed in years, which suggests that the parasite is probably dead by now. And so it's just living in his head. It's dead. There's nothing to do about, so not living, but he's got a dead worm in his head is what's going on. All right. It sounds really bad. It sounds gross, but it's not something that really probably makes a difference for him at this point. But in terms of like prevention, and this is probably probably where we're going with this, especially for the likes of somebody like you who's traveling everywhere, right?
Yeah.
So like I said, he's said before that he has no problem. He said no problem like eating whatever they eat in these local areas and so on and so forth. So he thinks it's from undercooked pork, from travel. Of course, that is, very likely what caused this. But how can you avoid it? I guess, well, first of all, if you're traveling to high-risk areas like Latin America, Sub-Saharan Africa, parts of Asia, okay, well, first of all, if you're going to eat pork, cook it thoroughly, because, if you get it to at least 165 degrees Fahrenheit through and through, you're going to kill any of the parasites.
Yeah, but when you're traveling, you're not cooking your food most of the time. You're going to a restaurant and they're cooking your food, and you're not going to walk around with the thermometer either.
That's true. That's true. So maybe avoid pork. Maybe. I mean, if you're going to one of these areas, right?
I feel like at least pork. Maybe just do more beef or chicken or
for sure. Yeah. And then there's like simple things like, washing your hands, like drinking bottled water, boiled water, all that kind of stuff. Like we know that. But then one thing to think about too is, a lot of people think that, okay, well, I'm not going to eat pork or I'm not going to eat this meat, but I'll be safe if I have some fruit and vegetables. But here's the problem with that is that most of those are washed with the water, right? So unless it's cooked, unless you're eating vegetables that are cooked, or fruits maybe that you can peel yourself, you're not being super safe. So it's a challenge. But bottom line is, that's probably what happened with Kennedy. there's a few tips there in case you travel, like Miss Nikki Leigh traveling the world and trying not to get parasites in her brain.
Thanks, Buck. Okay, we're going to go take a break, and when we come back, we'll talk with Dr. Sefi, a senior radiologist at Prenuvo, which is a full-body MRI facility that both Buck and I have actually used. Welcome back to Longevity Junky. Time for our guest interview. It's The Breakdown with Dr. Sefi from Prenuvo. We are here with Dr. Sefi, who is a radiologist in Stanford, California. He received his medical degree from the Warren Alpert Medical School of Brown University and has been in practice between 6 to 10 years. He's worked with Prenuvo for about 3 years, and he's here to talk with us today about full-body MRIs. Welcome, Dr. Sefi.
Nice to meet you. Thanks for having me on your show.
Well, diving right in, what exactly is an MRI and how has it been traditionally used?
So MRI is a medical imaging modality of which there are several types. Traditionally, you would think of, something common like an X-ray or a CT scan. And an MRI is another kind of modality that doesn't use ionizing radiation, in contrast to those other two modalities that I just described.
The CT scan?
CT scan, yeah, that involves dosing the body with ionizing radiation, while MRI uses a different kind of energy that doesn't involve that type of energy. The benefit of that being that it doesn't cause any damage to DNA over the long run, which can be a concern when you use ionizing radiation in those other settings. So both, many ways of doing imaging. MRI is one way of doing it, has that advantage. Additionally, it has a lot of very, special properties where we could do cross-sectional imaging. So actually like slicing up the body in different slices and flying through your anatomy as if it was looking at a textbook. And we can also manipulate parameters. So this is called multi-parametric MRI, such that every individual sequence, which composes an entire MRI protocol, can look at different features of tissue. So when we do that, we get a very good sense of the nature of your anatomy and the nature of the tissues and pathology that we encounter. Each one of those sequences has its own sensitivity, and altogether they add up to give us specificity and a diagnostic impression.
I'm a physician and a surgeon. I used to practice, and we used to do MRI all the time. But you're doing it a little bit differently, at least in context, right? Can you explain sort of, the traditional role of this versus how MRI is being used in this whole body surveillance?
Yeah, that's a very good question. So there's some nuance to sort of wrap our heads around here. This is a unique context of applying MRI. Usually MRI is, if you think of like a sort of a diagnostic pathway or like a pyramid, it's usually like the end point of this pyramid. It's the most sort of, usually the least available, most expensive modality to reach, but it's also usually the most powerful, and that's why it's usually the last line of defense when trying to answer a diagnostic question. But we take advantage of those attributes of MRI that describe being non-ionizing and having such a large kind of range of capabilities to characterize findings, and want to put it at the forefront of sort of the healthcare process. So rather than kind of waiting till a problem develops and not being able to answer it with other modalities beforehand, we want to bring it to the forefront and try to kind of detect abnormalities before they become clinical problems. And that's why we're applying it in the screening context. Now, as technology has evolved in the last, let's say 10, 15 years, those issues that have made MRI more out of reach and kind of a limitation are being relatively overcome. So the issue with expense, MRI is much less expensive these days than it was 10, 15 years ago. The technology has evolved such that we can do a lot of imaging in an efficient manner, so that we can basically do it more at scale as well, and the quality is improved as well at the same time. Traditionally, MRI being in a dedicated diagnostic setting is usually limited to a certain region of the body. Let's say the brain, they'll only image the head, and that'll be the extent of the whole MRI encounter. In our context, we've adapted the techniques of MRI and basically custom tailored a whole body protocol that allows us to image the whole body from the top of the head to the ankles within the same single MRI encounter. So the innovation here is both the application and then the techniques that have gone into custom tailoring that imaging protocol to make it efficient to capture the whole body in one encounter.
We talk about the ethos behind what we talk about in terms of longevity medicine. It's a shift away from the traditional defensive medicine to maybe a more proactive, preventative paradigm. But, typically if I ordered as a neurosurgeon, ordered an MRI, I would be saying, rule out something or another in the brain. And this is not that. This is sort of like, you tell me what's wrong, right?
Right, exactly.
There's something wrong, right?
So we purposefully tried to distinguish between a diagnostic MRI. What I mean by that is really the context that brings the patient to an imaging encounter, as opposed to a screening context. So in the setting of a diagnostic context, where as a neurosurgeon you want to rule out brain tumor, let's say,
right
here we're walking a fine line between balancing of, we want to document observations, and a lot of times there's small findings that are low risk. These are likely benign, likely not tumors, but they could be little dots here and there. We document them. We tell you what they are most likely to be, and then we monitor them over time. It doesn't mean that when we find an abnormality that it will be actionable in most patients. On the other flip side of that, it is risk stratifying, and when we do find something that we could tell, it's on all the imaging that we're doing. So all the different characterization with the different imaging sequences, we could say, oh no, this actually is something of concern. This is a tumor. We should work this up. We should send you to the specialist. We should get a dedicated study with and without contrast. Because here in our context, we're screening with no contrast, but the contrast adds one more level of detail. That will then risk stratify that patient to early intervention or not. So it is definitely that context distinction is really important. And there's this, people worry about incidental findings and what that means. When you send for a diagnostic MRI, you have one specific question, usually like rule out the brain tumor, and then everything else that we observe are, other things unrelated to that question, and those are called incidental findings. In our context, there's no real incidental findings because we're trying to document all of these at the same time. And I call them more like opportunistic findings. And then based on what we see opportunistically, we basically can say, see you again in a year for another routine checkup, and make sure that everything stays about the same and it's not progressing in a concerning fashion, or either act on it because let's say there is an obvious tumor or a big aneurysm or something, we can act on it early on, or see how it changes over time if it's small and low risk.
Prenuvo claims that their whole body MRI can detect over 500 different conditions. I mean, for reference, how many do we screen for in traditional screening?
Let's say maybe to narrow down the focus a little bit here to cancer screening specifically. Right. So, there's only a handful of specific cancers that are actively screened for by, general guidelines. So these include in women, breast cancer screening, cervical cancer screening, and both males and females, colon cancer screening, colonoscopy. And if someone is, at high risk for lung cancer, being a long-term smoker, let's say, they're recommended for low-dose chest CT lung cancer screening. And those have shown, benefit in terms of, over those screening protocols to improve mortality. But on the other hand, most cancers are still unscreened for.
Just to interrupt you real quick, just for clarity, because this is an important point. How many cancer screenings do we actually technically have here right now? Traditional medicine-wise?
It's only those 4 cancers.
Yeah.
It's I believe it's about 70% of cancer deaths are actually due to otherwise unscreened cancer. So all other cancers not due to those 4. So for many of those cancers that are not screened for, then you have an opportunity with this whole body technique to screen for all those other organs, which could also be developing cancer, even though, they may not be the more likely ones, but when you take them all together, it's you have an opportunity to catch them at early stages as well. So you can think of like screening ignored versus specifically screened single cancer focused approaches. And it's kind of like a paradigm, a different approach, paradigm shift between like looking just for the specific cancers in certain populations that are at higher risk for those cancers versus, taking a multi-cancer early detection approach to make sure we can also catch the exceptions to the rule or the rare cases.
500 versus 4 sounds incredibly different.
Just to clarify, those 500 are not all cancers. So it's a very comprehensive approach. So besides cancers, so cancer is definitely low-hanging fruit. I would say like every organ in the body, I'm going to comment on whether I see a tumor there or not. But we can go then beyond cancer. We can screen for, so Buck, talking about like, as a neurosurgeon, brain aneurysms, we include time of flight MRA imaging in the brain to look at the circle of Willis and to see if there's any, aneurysms that could be worth being alerted to, and then either intervening on before they rupture or watching, waiting to sort of risk stratify to see the ones that are growing versus the ones that aren't. We could do the same. We don't use as dedicated technique, but we can look at the caliber of the aorta and look for aortic aneurysms. We can look for metabolic disorders as manifested often in the liver, like fatty liver or hemochromatosis, and literally a very wide spectrum of conditions that could be manifested in anywhere in the field of view that we have, which covers head to ankles.
Yeah, but sticking to cancer for a moment, one thing I think to clarify is, so when you talk about the traditional screening and you have like chest CT and for smokers, colonoscopy, mammography, all these types of things, you guys are, I'm definitely not suggesting that the full body MRI is a replacement for those screenings.
Definitely not a replacement. So that's exactly the point. So it's a distinction between having like a gold standard test for that specific cancer in a certain population, and definitely everyone who fits that category should be going for those first line tests. So women who are screening age for breast cancer should get their memo. If you are, at risk lung cancer patient, you should be getting low dose chest CT. Same for colonoscopy. What this technique is with the Prenuvo whole body MRI scan, it's an adjunct to those. So whenever, in between screening checkpoints that you should be going for anyways, it's another opportunity to take a second look. And on the other hand, for all the other conditions that don't have a dedicated preferred screening approach, then this is sort of the next best thing to get another data point, basically.
So Nikki, one of the things that I think that you might find fascinating and yet scary, and Dr. Sefi can comment on this as well. So, I used to be in the brain surgery business. And specifically, I was interested in brain aneurysms, right? And you hear about brain aneurysms, they're basically these ballooning out of blood vessels that'll just pop in your brain. So it turns out 3% of the population have these, or walking around with them. Now, most of them don't rupture, but, when they do, it's almost always fatal. And if you do survive, you kind of wish you didn't survive.
Wow.
So it's now you've got a lot of really minimally invasive ways to treat those. When I started training, there wasn't nearly as much in the way of minimally invasive treatment. But now, like, if I am one of those 3% of the population, I want to know, because I want to get this thing sort of treated and not just find out, like, after a run, having the worst headache of my life and die.
Right. And Prenuvo can detect this.
Yeah. So that's actually a really good point, Buck. And I want to maybe hammer that in a little bit more.
Yeah.
When you take the capabilities of screening, including the Prenuvo scan, and you couple it with the sort of advances in kind of clinical medicine and interventional medicine that have, aneurysm treatment is one a good example, but all kinds of conditions are now more amenable to minimally invasive approaches. Even, let's say, an early stage tumor. When we let's say a renal cell carcinoma in the kidney, not too long ago, you had to go through a full nephrectomy to take out that whole kidney to treat that. But nowadays, with image guidance, we could put a little needle in there and ablate that tumor with leaving the rest of the organ intact. So when you kind of couple the advances in clinical medicine as well as the screening capabilities, the options for early treatment and avoiding, complications down the line, I think they're synergistic.
Some people are kind of also really hesitant about these screenings, right? Like, because I just mentioned 3% of this population walking around with an aneurysm, and there's probably 50% of the people out there saying, "Oh, I want to find out if I have an aneurysm," and then there's 50% of people out there saying, "I don't want to know if I have an aneurysm."
Ignorance is bliss, right?
So I'm sure you kind of deal with that all the time. I mean, what would you say to someone who's on the fence about that? You kind of addressed this already to a certain extent because of all of the, clinical advancements we've made, but, just hammering home the potential in the difference in outcomes with early detection versus late detection. And maybe the best example of that would be, various types of cancers. You could talk about maybe like pancreatic cancer or something.
That's a very good point. And again, let's focus on both the cancer and actually I think the brain aneurysm could be another good example. Not every abnormality that we encounter has to be treated or at least treated right away. It's a risk stratifying approach. And when we find a low risk sort of example of a pathology, and let's say not all aneurysms are created equal. So you can have a low risk aneurysm that's small in a certain location and not have risk factors like, hypertension or something like that, or connective tissue disorder. And you're going to be at less risk of that aneurysm progressing in a certain time period. So when I see a brain aneurysm, I usually give a phases score, which is a risk stratifying technique that based on a large data that's been published out there, that based on the location of that aneurysm, the size of that aneurysm, patient-specific risk factors, I can predict with some level of confidence the 5-year risk of that aneurysm rupturing. So based on when I see a low-risk aneurysm, I'll generally say something. I'll give the details of the size and location and all that, and I'll give the phases score and the risk of rupture, and that guides, does this need to be treated or can this be sort of surveilled and seen, checked up again in a year and see is it growing or not growing, as an example. Similar for cancers, like not all cancers, or let's say tumors are born equally aggressive. Some have a long indolent period where you can watch and wait, and some will require more aggressive intervention, like right off the bat. So pancreatic cancer is an example where that one is probably one. If I see a pancreatic tumor, I'm not going to want to watch and wait that one. That one is something we need to work up and probably act on right away. But some things like sometimes prostate cancer is a very common, even controversial cancer for screening in men, because many men as we age will develop prostate cancer, and it's often not going to be the thing that causes that individual to die. Like a long lead time where low-grade cancer can kind of hang around there, and they're more likely to die of something else before they die of that cancer. So you don't have to always take out, an 85-year-old's prostate just because we found prostate cancer. So there's this personalized approach as well that's important, and guiding, when to act and how to act will be important in that patient-specific scenario.
One of my friends actually reads for Prenuvo, and he was talking about how, and this relates to something that Nikki and I talk a lot about on this show, is just, metabolic syndrome and just having pot bellies and things like that. That's not something that you would ever see a readout on from an MRI, diagnostic MRI. But talk about some of those things we don't think of necessarily as in the diagnostic context, like subtle things like that. Basically you can see if somebody's kind of, what we call skinny fat, right?
Talking about something like visceral fat or that skinny fat, as you mentioned, that's important because that can lead to other medical problems that are, somewhat directly, but also not so clearly related, metabolic problems and other related issues. And so by, commenting on this, as well as related organ-specific manifestations like fatty liver, which goes along with that, body fat misdistribution condition. Fatty liver can predispose to liver disease in the long run. It can also predispose to other metabolic syndrome with diabetes and so forth. That's probably something that MRI is already gold standard for, like assessing fatty liver. Beyond that, talking about the visceral fat, it's not something we're actively doing today because we don't yet have like clinically ready, AI to do that. But AI will be automatically segmenting our visceral fat giving them a number like you have, X milliliters of visceral fat. And then if you want to do conservative measures to take off the fatty liver and take off the visceral fat, whether it's exercise and nutritional changes, then we can monitor that over time and see how you're on track with certain goals.
Now, I have done a whole body MRI with you guys at Prenuvo, and the report was very comprehensive. It was very thorough. I don't know if you, Dr. Sefi, do you have a copy of that with you at all?
I do. I did review it. And just to clarify, I was not the doctor that did the initial evaluation, but I did review your report so I can kind of talk about your findings on a high level if you want to do that.
Yeah, that would be great.
I had one too. Why don't you explain what it's like? Because it's a very unique experience, right?
Yeah. So my experience, I mean, I'm an action person. I'm a doer. I really love this stuff. So I was really excited to go in and do this, and also to be able to get an answer back that was going to help me, live longer and healthier, and be able to be something I can attack if it's at the early stages, rather than, something that's going to be, very negative to hear. And, we go in and everyone's really, really nice. And they, take you to a room where you get to change into basically scrubs type of clothing. And then we go into a really big machine. That's the whole body MRI machine. And you basically just lay there for about 45 minutes. It's not too small of a space, but it is still, a more enclosed space than our day-to-day rooms. But honestly, there was a TV right behind me. I'm laying down and they were like, "Oh, do you want to listen to watch YouTube or or something?" And I'm like, "What?" I was like, "Is this a break of life or what is this?" I just had them put on meditation music, and I just went into a zone, and I was just able to be, and all of a sudden it was over. So it really, to me, it was, a very peaceful way of taking hold of my own health, which was really awesome.
Well, it's funny because I actually, I had one too a little bit longer, a while back. And I remember the whole experience was very pleasant. It was sort of like going to med spa, actually.
Yeah.
And like you, when you laid there, they had Netflix. And this whole thing, the whole scan took an hour. I mean, just for perspective, when I used to order MRIs in neurosurgery, it would take an hour just for the brain, maybe if that. But so then just put the headset on, and I was watching some kind of, I think it was one of the NFL Hard Knocks things, and it wasn't over yet. So I almost felt like saying, "Hey, can I just stay here for a little bit longer and finish?" So it's very, very pleasant, I thought.
That's all very much by design. We want to make this an experience that is comfortable and convenient to the patient, not another burdensome medical test, because then it kind of defeats the purpose. This is meant to make it, give people, facilitate their taking health into their own hands and wanting to be proactive and take care of themselves. So the little things like that, like making the MRI, which is an intimidating experience, you're in that tight, space for a while, and giving you something to be distracted with, like being able to watch a show and so forth, and making even the medical office environment a little bit more calming and soothing. That's all very important to that experience, and actually hopefully going to improve the outcomes along. Because if people don't, want to keep coming back, then it's not really going to benefit them. Because the real value really is in getting the one-time baseline, but that's just one time. Then it's the kind of the longitudinal follow-up over time. It's much more similar to being the relationship you might have with your primary care doctor, and you have that continuity of care over time, and you have a relationship, and you can compare to how you were last visit and how you are this visit, and chart your lab value, lab test changes, etc. That's really the approach.
Right.
Here, we're patient-facing, and we're trying to give as much helpful, constructive, health-related information as possible from these encounters to improve long-term outcomes.
Having a whole different perspective on it, and having it just be a traditional, I'm just going to check up on myself, and nothing could be, there could be nothing wrong. But that's not how we think about MRIs yet. And I think making sure that people understand to see this as a preventative, and them taking control, and them having the power to be like, "I am healthy. This is good. I have proof."
Yeah, and it goes both ways as well. Like if we can see an abnormality that is something, it's not a cancer, it's not an aneurysm, but it's something there that, I think could be causing you symptoms, and if their symptoms have not been well addressed by, maybe you never brought it up to your doctor, maybe it was not put in context, maybe they didn't, they kind of lumped it in with like, oh, non-specific complaints. Often, women go through this a lot with like, whether it's like not well-defined pain symptoms or something like that. Something as common as endometriosis is often ignored for a long time until eventually it goes on for years. And then, whether you go for a diagnostic laparoscopy with a gynecologist or you go for an imaging exam with an MRI, and then we see that, oh, yes, indeed, that there's endometriosis there. As that's an example. So we can find findings that we might say, oh, this could be, going along with endometriosis. Do you have any symptoms? Because maybe there's something you want to talk to your doctor if it's causing you issues.
Well, why don't you use my scan, because we were going to talk about it, as like maybe an example of one of these things.
Yeah, we already know that Dr. Daniel Amen says that she has one of the most beautiful brains he's ever seen. So let's see what else is inside of her.
Yeah.
So, okay. Yeah, sure, Nikki. So yeah, I reviewed your scan, kind of an overview, and looked at the results that were reported. And your scan came back essentially as normal as they come, like a normal whole body MRI. I think there was a couple little, minor findings like a Baker's cyst in your right knee, which I don't know if it caused you any symptoms or not, but we see those all the time. And oftentimes they're small. They're not of any kind of clinical concern or significance. But there was no evidence for anything like a tumor or brain aneurysm or metabolic manifestation of liver disease like fatty liver or hemochromatosis. So it was, from a screening perspective, I think a pretty good clean bill of health. It's a good baseline to have that then when and if you come back for a future checkup, and let's say in another year or 2 years, let's say, and there's, hopefully no changes, but if there are small subtle changes, we can be alerted to them by comparing it to that baseline and put you into, early intervention or management or risk factor control versus just kind of continue with routine screening.
Yeah, no, well, that's good to know.
How do you just mentioned a year to 2 years. Like I was thinking about this because, obviously I had one of these too. And like, how do you decide like what the optimal time in between these things is? I mean, I guess in my case, I had like a benign looking cyst in my pancreas, and that made me think, well, maybe I should follow this yearly. I mean, like what kinds of things go into determining whether it should be a yearly thing, biannual?
Very good question. And we don't have the complete answer yet. The complete answer will depend on getting a lot more data over large populations and individual subsets of populations to basically give a strong patient-specific recommendation on what the ideal cadence is for them. That being said, we kind of generally recommend a 1 to 2 year schedule as sort of a rule of thumb based on, I would say, reasonable clinical judgment and experience, because, this kind of aligns with the sort of periodic health checkup schedule. Like people will go to the doctor, I mean, ideally once a year, but I know most of us don't really go once a year. I don't usually go once a year, but wait, once every 2 years, check in, make sure everything's okay. So the idea is to align on that schedule. From the perspective of like cancer screening, many cancers will have sort of a lead time where that like 1 to 2 year period is usually, kind of the standard cancer screening cadence, because that's when you can catch, interval growth of cancers, et cetera. So mammography generally is on an annual basis. Some guidelines are on a, every 2 year basis, depending on which society you follow. For somebody who may be like young and low risk objectively, probably reasonable to do it at a slower cadence, like every 2 years, because they're less likely to develop a problem in that time frame. While someone, once we get up in years, middle age and later, checking up on a more frequent basis may be helpful to kind of catch early changes as they happen, because that's more likely going to happen as we age.
Well, right now, you don't have insurance coverage for these things either. And, they're not cheap. So, I mean, I guess one question is, do you see, I would think that insurance companies might be interested in starting to pay for these things. If they can, integrated into sort of routine health care and surveillance, that they might find that they could actually save money. Are you seeing any signs of that, or at least some investigation?
I have not seen anything concrete about that. I think it will depend on us getting more data, and we actually are sponsoring a long-term clinical study, which is called the Hercules study, which was recently launched a few months ago in June. And the goal of that is to study the application of whole body MRI screening in a large segment of the population, general population. So 100,000 subjects is the goal then. That's the kind of level of study I think that we'll need to generate the actual utility of whole body MRI screening in the general population context. Certain companies that are internally funding for their employees as like a health benefit, because there's indeed like a long-term investment proposition for, cutting down the costs of future complicated medical care, like for late stage cancer, as opposed to early detection and less expensive complicated treatments earlier on. So there is definitely, I think those economic arguments are resonating as well. Not really yet with, as far as I'm aware, with like the traditional insurance companies, but other, relevant institutional level enterprises are actually looking at this as well.
Yeah, because I'd talked to actually the president of Grail, with the Gallery test, which is essentially a blood test for cancer. He was saying that some of the life insurance companies were interested.
Yeah, that's true as well. Yeah.
And correct me if I'm wrong, but Prenuvo offers several packages ranging from like 1,000 to 2,500. Is that correct?
That's right. Packages are basically differentiated by just, when we say whole body, we kind of mean that term relative to, dedicated MRI, which is like segmental, but it's still a large field of view, but they're relatively smaller portions of anatomy that are covered. So the traditional whole body, which is the top of the head to the ankles, is, the higher level of those options. Then we have a kind of relatively abbreviated head to torso protocol. So it goes from the top of the head to the bottom of the pelvis. And then we have a torso focus exam, which is not including the head and neck, but just looking at the chest, abdomen, and pelvis. And these are just various different options based on, they'll cost different amounts of financially, and patients may have, interest in doing, more focused versus complete systemic evaluation.
I was going to ask you, one question I had was about early detection of Alzheimer's disease. Is that something you can do much of with MRI? I mean, obviously, once you've got amyloid plaques, neurofibrillary tangles, and stuff like that, you get real disease. But sometimes, do you guys kind of look at some of the things that could be suggestive of early dementia?
As we continue to iterate and optimize this approach and the scan technique, that question is something we'd like to start looking into as well. What we will start doing, or can even start doing in the near future, the brain has a sort of a kind of a natural age progression where it'll shrink in certain parts, and that's part of normal aging. But when you have certain areas that shrink faster than typical for a normal aging curve, as happens, let's say in Alzheimer's with like the hippocampal regions, we could potentially be alerted to that by monitoring someone's own brain volumes and the individual structure of their brains over time, so that if they're falling off their aging curve, the thought is they could be alerted to something and maybe have a opportunity to have a, disease modifying intervention. Let's say it's a conservative like lifestyle change with dietary or medication or something like that. That'll be in conjunction with specialized centers that are looking into that as well.
Okay, before we wrap up, Dr. Sefi, how can listeners find out more about Prenuvo and schedule a scan if they're interested in taking a proactive approach to their health?
Find us online, go to our website, and you can see like where our locations are, which are, now in multiple states across the U.S., and then find the one that's closest to them and try to either book directly online, which is an option, or they could call into the general, customer service line and have someone help them on the phone.
Thanks for joining us.
Yeah, this was very informative. I really hope that there are people out there who really want to take advantage of the fact that they can be told early on how to monitor their health and just kind of take the power back, really.
That's our goal. Well, thanks very much for having me. Really appreciate being with you guys, and nice to meet you.
Yeah, nice to meet you too.
Take care.
All right, we're going to take a quick break and we'll be back with our healthy takeout. Welcome back to Longevity Junky. It's time for our healthy takeout.
So,
I mean, I love the fact that there are more opportunities now for us to take our own health into our own hands, like to give the power back to the people. So that's one of the reasons I was really excited about guinea pigging this and actually being able to talk from experience and, let the world know that it's not a crazy experience, because we associate any sort of imaging with a negative outcome.
yeah, no, it is. I mean, like, up to now, like, if you have to get an MRI of your head, that's not because of something good, right?
Right.
I mean, you're going in there expecting, what could be going wrong, right? But yeah, I mean, it's part of the bigger thing that you and I have been talking about quite a bit, and we alluded to it at the beginning of the show. Peter Attia calls it Medicine 3.0. And what that is this switch from a really defensive type medicine. The defensive medicine, it's not like it hasn't done us a lot of good. I mean, we've made a huge amount of progress in the last 100 years, been able to cure people of disease that we couldn't do before. But even through that time and up to now, it's still defensive. I mean, you heard like how many screening tests were there total versus 70% of cancers that we don't screen for that kill us.
That's crazy to me.
Yeah. And so this is the ability to sort of, take that back and play offense, because at the end of the day, medicine is going to do what medicine is going to do. Hopefully there's an evolution of that. But in the meantime, we can harness a lot of this technology and things that we can order on our own and do on our own to take our health into our own hands. Yeah.
And I like that, it's technology isn't just like the iPhone. That's, I really kind of believe like all these things are like bad for our mental health, but we're able to see technology actually being something that's a positive for us and that can benefit our health.
Right. Yeah. And, the other thing just to put this in context, I don't think the technology replaces your doctor. That's important. Like, I'm a firm believer that ultimately, like, people should try to find doctors that they can work with. We'll talk sometime about heart rate variability, but I think that's a very important measure that is recorded on everything, like your Oura Ring, your Apple Watch or Whoop, whatever. But being able to come into your doctor and saying, hey, I'm getting these readings and I don't like it. What do you think's going on? That's huge. That's something
powerful.
We've never had in the history of medicine.
Yeah. And I mean, doctors are so like inundated with like people coming in and being like, oh, something's wrong. And so, a day in the life of a doctor is not necessarily pleasant, right? I mean, all they're hearing are people's complaints or ailments or things like that. And honestly, they're not always able to come at us with a fresh mind. Quite honestly, I don't go to my normal doctor, primary care doctor, and do these routine checkups. I mean, granted, I am doing these guinea pigging things, which are incredible, and I'm so grateful for them. But
and you call me.
Yeah, and I call you. I legit am so, Buck, I love you. I am so grateful for you. Truly, though, like not everybody has, the benefits that like I do. So,
sure.
So it's like, I want to be able to be like, hey, you guys can actually have any of these benefits that you're like, oh, why does she get this? You can actually have these measurements too. And you can have this power too, to be able to bring to your doctor and have your own argument. I mean, how awesome is that you can actually have things to contribute to the conversation with your standard doctor?
I think the thing that people need to get armed with is knowledge. Like, you've got to read up a little bit just on some of the basic things that we read up or listen to podcasts, for example, ours, where we talk about these things. So, for example, we've talked about Oura rings, and we'll do an entire episode on sleep at some point here. We've talked about continuous glucose monitors or Apple Watches. All of these things, what they are going to allow you to do is to basically get data, but you're going to need to spend some time trying to learn what that data means. And that, in my opinion, is sort of on the individual, because the technology's there, right? Like, we used to be able to say that, hey, it's not like, we know more about our cars than ourselves. And because, there's a fuel gauge there, and there's something that gives you an alert when your oil is low or something like that. And we don't have that for ourselves. Well, we actually do have that, but you gotta know how to use them. And still the vast majority of people out there don't. So that, I think, is something that we can change and sort of empower ourselves with.
Yeah. Well, and to like what you mentioned kind of in the beginning about like gamifying your health, there's so many young people out there too who, they're very interested in, playing their video games. And so if they can actually be an active participant in this game called life.
Well, having fun with health, right?
Yeah.
Having fun with health, because usually, the things that we do to be healthy usually aren't supposed to be very fun. But if you can gamify it, at least it gives you a little bit.
Yeah, it's very true.
Good thoughts on that. You want to read us out?
Yeah, of course. Longevity Junky is created by Dr. Buck Joffrey, MD, and Timothy Fonara. It is executive produced by myself, Nikki Leigh, Buck Joffrey, and Timothy Fonara. The show is produced by Pretty Fast, and Phil Ferragamo is our producer, and original music by Alloy Tracks. We're distributed by our friends at Acast, and see you next time.